We're going to try this again. I think maybe we have some audio here. I think we do, actually. That's exciting. But tell me if you see it. I'm going to go to try to get to this again on my other phone. Wait a moment or two to actually make sure that there's something on. Okay, can anybody hear me? Anybody hear me? Anybody? I see there's four of you. Oh, Tina, thank you so much. Okay. So it seems like every time I do this, about 20 minutes into the attempt to try it, there's finally someone who responds. Ah, yes, we've seen you finally. Sorry about that, guys. All right, so awesome. All right, so I'm gonna go through this again just a little bit, and then I'm gonna try to get to the questions because there may be that you might want to hear questions more than you want to hear about shoulder. Um, okay, so the difference between we want to talk about the difference between a stiff shoulder and a weak shoulder because those are different things. When we talk about frozen shoulder, or that work, where a frozen means that I can literally take your arm and I can lift it up. You may be weak, but I can do it. If I can't do it, that means it's stiff, right? Stiff and frozen, same idea, same context. Weak means that you can't do it, but I can do it, right? Let me say that again. If I can lift it up, then you're not stiff. If I can't lift it up with my own power, right? Your power, but my power, that means you're stiff. And there's a couple different reasons why people might get a stiff shoulder or a frozen shoulder. Um, we know that diabetics are more likely to get a stiff shoulder or frozen shoulder without an injury, and even with an injury, actually, too. That's because diabetes does, right? This elevated blood sugar. When we have elevated blood sugar, that elevation of blood sugar actually creates some glycosylation, or there's little pieces of glucose get stuck on collagen. In doing that, the collagen changes its properties and actually becomes more sticky and more stiff. The collagen fibers stick together better, and that creates this stiffness. So even if you don't have an injury, right, you can have a shoulder more because of sometimes to do with some viral illnesses, but also has to do with again those kind of inflammatory responses that are more like. So that's pre-surgery. That's no surgery, no injury, right? You can have injury on a stiff shoulder because of some inflammation in the shoulder, and then obviously after surgery, you can have you had an injury, or we did this injury, an injury going there to fix your rotator cuff, or what we're doing in there. That inflammation will create stiffness. Almost everybody, not everybody, but almost everybody after surgery is going to have a stiff shoulder for a period of time. And it is normal to have a stiff shoulder for a period of time, for a long time, probably for 3 months. And even what I would tell my patients is that I don't know that you're going to have a shoulder that is 100% normal, like completely full um, uh, range of motion. Some people get there, some people do not get there, right? So it's so that's different. I think stiff means it's inhibiting your ability to do normal daily life. If you can get to here but not here, I mean that may not be, but it's probably not something that's really a functioning in your daily life. So that's where I think that's different as far as just long term. If you can't move in a relatively functional range of motion at 3 months, this is a warning sign to most surgeons saying, okay, well, this is something different, right? This is not a normal post-op stiffness. This is a more advanced stiffness, and then we have to do something about it. Again, that something sometimes is a medication, sometimes more time in therapy, how if you're still progressing, right? If you're hitting plateau, then at 3 months, then we might, in a significant decreased range of motion, we might decide to do manipulation, which is where we put you to sleep, and then we physically move your arm, break up the scar tissue. Actually, there is a noise that happens. The in the room typically not like that noise. It gives them little shudders when we do a manipulation because there's kind of this ripping sound. But oftentimes it's helpful and gets people a lot more range of motion than they had before the manipulation. You go back to try and maintain that range of motion. So that would be after surgery, stiffness after surgery. So someone was on here before, Ed talked about protocols and whether what there's a concern that he was at 3 months and it was behind the protocol, and he was worried. He didn't understand why the therapist was so set on the protocol. Protocol most likely has been set up by the surgeon, and so the therapist wants to make sure they can maintain the protocol because that means they're doing a good job. I mean, that's what they think anyway. And obviously, just because you're falling off the protocol doesn't mean that the therapist is doing a bad job. Doesn't mean that you're doing a bad job as a patient. It just means you're not in that exact line of the protocol. And so oftentimes that protocol, there has to be a little bit of laxity or of a leniency in the protocol because not everybody's going to be perfect. Not everybody's going to be able to stay in that protocol, if that makes sense. We're going to have people a little bit faster, people a little bit slower. That's just a general idea of where you ought to be at 2 weeks and 4 weeks and 6 weeks and 8 weeks. So that protocol is important, but it's not like you have to hit every little bit of the protocol to be okay. So that was one question. Scott had a question about prepping your body for surgery. This goes back a little bit to stiffness. If you're stiff, then we would like to try to get about as much range of motion as possible. We want to get that stretching that capsule out, because if you're stiff before surgery, it's going to be a lot more likely you're going to be stiff after surgery. We want to make sure that if you are going to that if you're stiff before surgery, you do your best to get that motion. Beyond that, obviously, getting a good night's sleep, getting your house ready, and we have a video about that. I'll link to that video. Getting your house ready, getting everything ready so you're ready for surgery is important. Mentally, physically, everything's good at work, everything's good at home. You have meals made, all those kind of things. That's more important to me than what you're actually physically doing before surgery. Obviously, we want you to have a relatively healthy lifestyle before surgery. We'd like you to not drink excessively. We'd like you not to smoke before surgery, right? Those kind of basic things. But as far as any grand things that you should be doing physically for your body, probably not. Rest is important. That's good. Important too. But in general, unless you're stiff and we're trying to get the stiffness out, there's probably not a whole lot of things physically for you to do before surgery. That hopefully that makes sense. Okay. Anybody has any questions? I have a few more questions here, but anybody have any questions that I can answer for you, since we're all live and we have a few people on here? And I will give you a chance. And let's see, I'm going to put this here. All right, I put a question in the chat and see if anybody can answer that question. I'm going to do another question after this. Okay, Dave, that's a great question. So the question from Dave is, I recently had a superior capsule reconstruction. How will I know if I damaged the graft? Okay. So a supercapsular reconstruction is usually done because it's an irreparable rotator cuff. The rotator cuff cannot be repaired, and therefore we need to use something that kind of recreates to some degree the mechanics of the shoulder. So if you can imagine, this is the socket and this is the ball, and the rotator cuff kind of links them together. So when the rotator cuff is not functioning anymore, the head will rise up, and that makes it impossible for you to elevate the arm because it's stuck in the acromion. And so what we'll do is, if we can't put the rotator cuff back across and hold it down there, we'll put a piece of tissue from here to the socket, and that will help hold the ball in the socket. Now, that helping hold the ball in socket is helpful, but as you can imagine, it's a connecting. It's not and it's not their own tendon. The function is not as great. Most of the time we have some rotator cuff muscle integrity in the front and the back of the shoulder, so you do have still something to use, something that can work. So you can do some elevation. I don't know how much function you had, but the graft has to be a specific kind of graft. It has to be a thicker graft than sometimes we use for other things, and it has to be attached with anchors on both sides, and so it can fail. It's that it's hard to know depending on where you are in your recovery. It's hard to know for sure if it's failed or not without being. You could get an MRI or CT arthrogram. So you would, if you did one of those, you would be able to see if the graft is still where it's supposed to be. So that's usually the way. But if it's early on after surgery, oftentimes we would not do anything because uh, you can't tell if it's failed in your recovery early because it's not working very well, but nothing's working very well in the beginning. So it's usually time, seeing how you're doing in your recovery, and then ultimately getting it some kind of imaging study if it doesn't seem like it's getting better. And if it fails, the SCR, then you can obviously do SCR again. There are some other things you can do depending on your age. You can actually get a reverse total shoulder if you're, so there's options. So there are still options, even if the SCR fails, there are still options out there that you can, that you can, but I just get with your doctor and have the conversation. All right. I think Brandon taught is about BPD 157, and I don't even know what CJC 120 and 1295. But peptides are very interesting, and what we do know is there's not really any great scientific data. There's some anecdotal data, there's some animal study data, but there's not great data out there in the traditional medical community to say yes, this works. I think, you know, it's beyond the scope of an orthopedist to know about these things, at least at this moment. I think there are still some studies that are coming out, but it's really unclear whether these things can be helpful and whether or not they might even be harmful. So I think you really need to do your research. Your research more than your surgeon about any sort of peptide therapy. But I think peptides are very interesting. PRP is very interesting. Stem cells are very interesting. I think we have a lot of options. We just haven't quite figured out the right secret sauce, so to speak. Unfortunately, in the realm of medicine, we are not trained there, and so I think we need additional training after we get out of school, after we get out of our training. Also, and we need additional desires to think outside the box, think differently than what traditional Western medicine is, and that's uh, when there's so much to learn in this lane. To think about learning in other lanes is tough. I am actually researching BBC 457 and other peptides to see if there are things here, and we'll be doing a video on this in the near future. Interesting enough is, and maybe you guys can tell me, um, the the video I put out for supplements, and I talked about 5 supplements that are important, is probably the worst performing videos that I've ever done. So if you can tell me down below, is there a reason why that is? Is there not that many? Is there not that many or care about supplements or even the BCP 127, that kind of stuff, peptides? Do you just not really care? I much better talking about what not to do after surgery. So I would like to know if you have any idea, Brendan, if you have any idea why, or anybody else has any idea why that video performed so poorly. Actually, I was very proud of it. It was one of my best videos ever, but performed poorly because people are not really that interested, I think. Okay, I'm going to move on to Tina. Third repair in 14 months. Ugh. That's really hard. Let's see. Donor graft, extensive debridement. Well, and Tina has a question about pain after surgery, 6 weeks. If you've had 3 repairs in 14 months, 6 weeks after your third repair, I would expect you to have a fair amount of pain, because that just every time you go in there, you just re-irritate. So, I mean, that's a pretty significant trauma to your shoulder. I mean, I don't know. I would really just talk with your doctor. You may need different medicines, right? You may need strong medicines because perhaps you use the medicines appropriately in the first 2, but maybe that you need some more now because you've been taking medicine from before. Sometimes we do develop a tolerance to those medicines, that we might need actually more in the third surgery. And I hope that your third surgery works. And if it doesn't work, I don't think I would be doing the same thing again. Again, this is not medical advice. Yeah, I think, Tina, if you're not on anything except Tylenol and ibuprofen at 6 weeks, either you have a really strong pain tolerance, um, because I would think that was nearly enough. Um, and you say you can't take narcotics, and that makes it tough. There has to be something else out there that can help you. There has to be something else. I mean, that's just uh, that's a horrible situation to be in. Lots of ice, obviously, but there has to be some other things. There are other medicines just besides Tylenol and ibuprofen that you can take that may help your pain, that may not be narcotic specifically. Okay, let me look for the next question. Actually, I'm going to take this question over here. Yeah, so there's a question in Brandon, this kind of goes to your question too. 60% supraspinatus high grade tear, but very functional. So this is a tricky thing because generally we talk about thickness of tears, right? We talk about the rotator cuff maybe this thick, and if it's just torn a little bit through it, then it would be a low grade. Let's say if you said a 20% tear, right? 20% is torn, that means 80% is not torn. We get to 50%. 50% is interesting in that if you're at 50%, that may be where we start thinking about not just cleaning up the tear, because sometimes you go in there, clean up the tear, and that's all you need to do, and it will heal itself. If it's 50% or more and you have 60%, well, I mean, that's not all the way through, it's 60% way through, so more than half. And that's, so if you're functioning well, then I think you have, then there's discussions of whether a 60% tear may have some wiggle room as far as what to do. And it often has to do with how much pain the patient's in, how much function is lost too. So when we talk about, again, rotator cuff tears, we talk about the thickness this way, right? But so if we look at it from the MRI from the side here, right, and the rotator cuffs here, and that's that thickness here. So you can have a full thickness tear, which means a tear that goes all the way through your rotator cuff, but it doesn't go through all of your rotator cuff, if that makes sense. So if you look at the thickness here, if you turn your shoulder this way, you might just have the tear of this part of the rotator cuff, but this part of the rotator cuff and that part of the rotator cuff may still actually be okay. So that's where it gets confusing, a full thickness tear, but not a full tear of the rotator cuff, meaning that you may only have a full thickness tear of part of your supraspinatus. And you don't have that, Brendan. You have a 60% tear. So you have partial tear of part of your rotator cuff, I would say. So I think that there are lots of options as far as what should be done, what could be done. But again, a lot has to do with what your exam is, right? What you show your doctor, what you tell your doctor, how much pain you're in, and then what your MRI shows. And the other part of this is, the MRI is a pretty good study. But it's not that easy to tell the difference between a 45% tear, 50% tear, 55% tear, right? It's not that clear. That the MRIs are not that good. And so if we're in the middle there, it's challenging to know. I've seen MRIs that look like there's only minimal tear, and then you go in and you look at it, and actually it's almost all the way torn through. It looked like it's a 40% tear, and you go in there, it's 90% tear. So certainly that can happen. And so the MRI is good, but the MRI is not the end all be all. And that's what we have to make sure. That's why you need the physical exam, right? You need the doctor looking at you, looking at your shoulder. You need the history. We need the story, your story, and the level of pain and dysfunction you're having. And then we need the MRI too. And even with all those things, it doesn't say we have to do surgery. It just gives more of a direction. Could we maybe do therapy? Could maybe do injection? Could we do injection of PRP, right? And so there's some good studies out there talking about PRP in helping heal partial thickness rotator cuff. That may be an option too. The problem with PRP, as you all probably know, PRP is actually not covered by insurance typically. So PRP, 500, 600, whatever, somewhere in there for a single injection that may or may not work. So sometimes that becomes cost prohibitive for certain patients. Okay. All right. Any other questions? Let me see if there are questions here. All right. So I'm going to put another question. Why people not like my supplement? All right. Here's a question to you. You're welcome, Tina. And I'll go back to David. So if I had a patient that was able to lift their arm above shoulder height at 8 weeks after surgery, I would say that's pretty good. Is it where I want my patient to be? Depends a lot on what exactly was done, how bad the cuff was, how bad. We talk about the severity of the cuff, which means not just the thickness of how far it's torn, or so the severity is the thickness is torn all the way through. Also retraction, right? Is it torn and pulled back? That's what retraction is. So if it's retracted, that's a big deal. And that maybe get harder to be repaired. Actually, the tissue itself, right? You might have really good tendon, maybe good quality tendon, but maybe not. And if it's not good quality tendon, then we have to be careful as well. We got to make sure that we're not, and make sure that tendon, if it's more thinner, right? So the rotator cuff may be thick, or this thick. If you're an older person, you might have a rotator cuff that's that thick. And so even if you have a tear all the way through, even if you repair it, you still have a diseased tendon that's not working quite perfectly. All right, I'm still waiting for my answer. There's no one answering. So I don't know, I can't tell who's here. Can I? No, I won't tell me who's here. So does anybody have the question? Anybody have a question for me? Okay. Thank you, Tina. I'm not really to watch the video. I'm just curious why that video did so poorly. In YouTube land, we look at views in the first week. We look at how many clicks, so I can see how much YouTube showed the video out to people, and then I can see how many people that it was shown to actually then clicked on it to watch it. And that video has a really poor click-through rate, what it's called. And I don't know why. But to me, it says it's not really important to learn about the audience. My audience is not really that interested in that supplement. Which is fine. Then I will make sure that I do videos that I will try to find the audience is interested, right? Because I want to bring value to the audience. Okay, so Rebecca, hello. Bad nerve block caused what feels like inner ear pain 1 week post-op. It feels like an earache. I think there's lots of things that can cause that problem that time after surgery. I mean, it could be their nerve block, I guess. I mean, obviously the nerves are coming from your neck that go out to your shoulder, and they do a super inner scaling block, right? And so I suppose that's possible. I think anything's possible. I think the position that your shoulder and your arm was at the time of surgery, the amount of traction that was put on there, right? So depending on what kind of surgeon you had, there's two ways to do surgery. One is in the lateral position, so literally like you're on your side, and one is in the beach chair, which is you're sort of like leaning back. And then either way, there's something that's holding your arm and pulling a little bit of traction, pulling a little bit of force on it to open that space up so we can see what we're doing. The fluid that we pump in there does that too. And so those two things, if we have some traction, or even if it's too much fluid, so you can adjust the traction, right? So that means you can put more or less tension on it. We try not to put a lot in, right? So that's important. And then you can adjust the fluid rate, right? And so that's why you get this big bulky dressing on after surgery, because we want because we're pumping your shoulder through with fluid, so the fluid kind of circulates, gets the blood out of there, so we can see what we're doing. Also, it opens the space up too. And so if you have a lot of fluid, if there's a high pressure, or if there's increased traction, those two things could create some irritation there too. So it could be the nerve block. I don't know. Typically, what I have seen in nerve blocks that are not ideal is one is don't work, or they don't work very long. I've seen that, or they may cause some residual numbness in the fingers that kind of that stays for a while. Like it's even after the time, there's still some changing feeling, and I've seen that in the hand. Almost always that resolves. Ear aches not quite as much. So that's my answer to that, Rebecca. Mark, uh, let's see. I don't think most people think about supplements when it comes to rotator cuff recovery. That's fine, great. Again, I really want to know. If it's not that important, then I want to make sure I make important content. Okay, so I'm going to talk to Rebecca as the question. So even, I mean, so Rebecca says maybe it's a failed nerve block. If it's a failed nerve block, well, just because it's a failed nerve block, which means maybe they didn't get it exactly in the right position, doesn't mean they couldn't irritate something while they were trying to get the nerve block in. That's just can happen. Brendan, I don't understand what you said. Sorry, Brendan, just FYI for your audience, I suspect it will look better once he's inside, as I've recovered well, seeing 80 patients per week, including rotator cuff rehab, pre-post open patients. Not sure I understand, Brendan, but that's okay. Yeah, I'm not, again, so I can't find this anywhere in the UK, allowing for delivery from the US. Yeah. No, I don't, I mean, that video, that some video, I do just describe the supplement that I have, but I would never expect it in the UK or anywhere. Yeah, I was in Canada having a hard time getting it, so I wouldn't expect that. But it's not really about buying my supplement. That's not really the question I was having. My question was, why did so many people not even to watch the video? And it was showed to people and they decided not to. Again, it's fine. I just was wondering if anyone had a question. So anyway, all right, we have a few more minutes. I know I messed this up again. I started late, so I apologize for that. I have a few more minutes. But so we'll talk, and I'm going to answer Maria's question, and then if there's, and I'll answer one more question if there's another question. So if anybody has one more question, I'll answer after Maria's question. It says, I was post-op, full tear, biceps tenodesis. My doctor said I can go back to the gym, gradually increasing weights and limiting any overhead exertion until the 6-month mark. Why does my shoulder feel more stiff post-workout? Well, your shoulder not recovered yet. I mean, at 4 months, it is a good amount of time. And the fact that your doctor is allowing you to go back and do working out at this time is a really good sign. Because I would think for me, at 4 months, you would have to be doing pretty well for me to, yeah, you can gradually go back to the gym. And I would actually have to trust you. And Maria, you sound like a very trustworthy person. So I'm sure that's why. But the shoulder is not going to feel normal. And actually, it may never feel normal after this recovery. However, you can expect it to improve, I would think, over time. So I think that there's still some scarring in there. And if, even if the rotator cuff is healed, it is not like it's the same as it was, or it's not as if it goes back to like nothing ever happened. Most of the time there's something that is not quite right. It feels a little stiff, feels a little different. So I think that's why but if all it is feeling more stiff, you probably have more inflammation. And so consider, talking to your doctor about whether or not it's safe for you to take anti-inflammatories. Maybe you can take an anti-inflammatory before you gym. But again, I would talk with them. But I think it's very common for people, once they go back to working out, And kudos to you for going back to working out 4 months afterwards. That's awesome. Good job. But I think that I would not expect you to feel normal for a long time, and maybe not 100% normal ever. So, okay. So Rebecca gets the last question. Thank you. How often do you recommend icing nonstop or intervals? And so this depends on a few things. And in general recommendations, right, not specifically for you, but in general recommendations of a rotator cuff repair, I like constant ice as much as we can for the first 48 hours or so. Beyond that, I think I like ice after therapy. I think that's helpful. Warming up before therapy, icing after therapy. I think that if you're still getting relief from the ice after the first 2 days, 20, 20 on, 20 off, I think is fine. Icing is less important as time goes by. Icing is super important, trying to control the inflammatory response of your injury during surgery. So I think the first couple of days are super important. I think it's important after having therapy because that will calm it down. I think it feels good for you. It feels good. It decreases inflammation. It decreases pain. Then I would say that's more of that after you've gone through the first few days. I think icing is helpful. I mean, quite honestly, if a patient asks me, can I use the ice machine all the time at 2 weeks or 1 week after surgery, I wouldn't be against that. I don't think it's going to do any harm. And depending on exactly what your ice machine is, it might actually do a little compression too, and that may help you as well. Thank you. So that's going to be it tonight. Thank you all for being patient with me. This is the third live, and each one is still kind of crappy. It's getting a little bit better each time, and I'm going to keep trying. So thank you all. Appreciate it. Any comments, any questions, you can put the questions below. This will become a recorded video, and so you can watch it online after I clean it up a little bit, get some of the ums and the uhs and a's out. But thanks for to be with me, and I appreciate you. We'll see you again in another video, another live coming up soon. Thanks.